Yeah, thank you. I'm Ben Owens, I'm an ED consultant in Sherwood Forest, and we work with ESIST. I'll let Bharath introduce himself.
I'm Bharath Lakkappa. I'm a consultant geriatrician, mainly focused on community geriatrics, and I work in Northamptonshire.
Cool, thanks. Next slide, please. This is the slide. It's a bit of a joke with a serious point in that the risk here. We often hear clinicians and staff and systems talk about risk in their organisation and risk sitting with them, and actually ultimately this risk sits with the patient. And this is how we do it. And this is sort of a slide and a serious point is that the only way to reduce to not have any risk of falling, for example, which hospitals can sometimes be assessed with, is they never walk again, which carries huge risk and reduced life expectancy. So none of us want to live our lives like that. So I suppose it's just that thing. We can't eliminate risk. It's about balancing risk, and when we're in crisis, it's about how the risk of doing something which we're often all scared of versus actually when we don't do something, we don't take an action, that also has a significant risk, and sometimes we have to balance that off, and what we do will vary depending on the situation that we're in. Next slide, please. Why does this matter? Well, crowding, when the system falls apart, it causes two big risks. It causes crowding in emergency departments and sometimes delayed ambulances, which really means people sit at home waiting for ambulances, and they're probably the most vulnerable people in the whole system. Crowding in EDs is harmful. It's always been there. It's a measure of the system function. It's the only place that has no limits on how many people are in it. Everywhere else usually has numbers of staff to patient ratios, and COVID just makes this worse. We see ambulances held outside EDs. It's the only part of the system that has no full switch. It's probably a measure of how well the system is functioning overall. But also, crowded hospitals have a knock-on effect. We cancel operations, which has a knock-on effect to people's lives, and knock-on effect to the system. We make patients outliers. Outliers have a higher mortality and longer length of stay, which causes stress for staff. And a long hospital stay causes deconditioning, non-nosocomial infections, loss of independence and confidence. And actually all these things. So every decision we make about a patient and how we set our systems up, normally and in crisis, affects all patients. And then clinicians, we need to think about, if I admit this patient, it not only affects that patient, but it takes the bed off the next patient or someone else. So every decision about a single patient actually affects all the others, and that's when the system goes into crisis. Next slide, please. So really, this is about how do we manage risk in escalation. It's, as I said, we believe it's very much about risk management of patients. You manage, and that will change depending on the scenario and the system. We have to balance out risks.
I'll get to that in a second, Bendy.
And go for it.
The biggest risk management is talking to the patients. The patients usually tell us what they want, and we just need to be understanding and ensure that we can provide what risk is acceptable to them. The balancing risk is between two things, the patient and the staff members itself. Patients usually will tell you how they feel. It's also, we need to manage the risk of the staff. Staff, it's dependent on the training and the support they get. When they're in doubt, having somebody senior to be able to do an SBAR situation, background assessment and response kind of a feedback to the staff increases their experience as well and ensures that the risk is maintained. The biggest things which we forget in assessing is what kind of system they're using. One of the things which National Early Warning Score 2 can be useful is you might pick up the patient quite late in their journey. The other things is if you can add certain parameters in their training and ensure that they communicate all the time. When Laura and William touched on communication, it doesn't go anywhere else as well. Over here, through with patient care. The communication between teams, it's been much better during COVID time, and especially now people are not hesitant to pick up the phone or set up a Teams meeting for a few 10 minutes or 15 minutes just to see faces, and that seems to work as well. And avoidance has become even bigger thing with the DTA. Pathway 2 is complex. Trying to get them out quicker also means that the patient's risk can be assessed at home, which means the risks weren't picked up in the hospitals but picked up in the community, but able to communicate between the health and social care teams is quite important too. Social admissions, I don't think patients really want to come in anymore, but they still need some kind of help. But asking them what they need, and if we can provide that along with the escalation of care with health and social care, that's acceptable. There are a few predictable things which we have in our control. Palliative care and end-of-life care, patients know, patients are in registries, or we can do quite a few things. But predicting end-of-life care along with the patient and the family members is important at that given time for that patient. They do have phone numbers, they do call, and us able to also ensure how to differentiate the patients, whether it's routine care, which can wait for up to 7 days, or urgent, which needs to be in the next 48 hours, or emergency in the next 24 hours. If they don't do anything, they will need to go in, or the patient's been refusing, and we can hold them and then send them in, depending on what the condition of the patient is. What we also need to be very clear about is staff competencies. Shielding of the patients helped us out in a clear view of the competencies of the staff. They might be the same banding, but they have different competencies. So understanding that and putting training in place is really important as well. And again, communication between nursing, geriatric, community geriatric, social workers. We do have really good volunteer helps, and also biggest thing which we found was the families can support their loved ones even if they don't visit. They can actually be on the phone with them, ensuring that instead of healthcare workers going in or making phone calls, they can do regular updates. Next slide, please, and Ben, please.
Thanks. Again, so communication is the key. We keep repeating that, but it absolutely is, and I think COVID's shown us that. It's also planning for escalation. So most crises are predictable in some way. We often see it around bank holidays. We see it around, as example, in the NHS, bank holiday weekends can go badly, and I'm going, why? How did that happen? Every time the same thing happens. We're getting better at planning for them. But actually, yeah, so planning for escalation, either predictable escalation, such as bank holidays and other things, but also unpredictable escalation where the system just gets crowded because things go wrong or things change, is crucial. Actually, if everyone's planned and know what they need to do, it will go much better. Communication, so the ability to speak for community teams, for paramedics to speak to GPs, to speak to community geriatricians, to speak to hospices around end-of-life care, but also to speak to hospital consultants, can massively reduce unnecessary admissions and perhaps manage people at home. We can avoid coming to places like ED or hospitals, using community services. 111 first is obviously coming in, and making sure that's fully available 7 days a week is vital. A lot of crises happen in systems over weekends. A lot of hospitals see real turmoil and systems on a Monday morning. Admission avoidance. So do we have discharge teams in the emergency department in the admission areas, or actually do we have access to the community discharge community teams so we can discharge? People will feel confident discharging patients if they know they'll be picked up and there's a safety net in place. So communicating about that is vital. Front door geriatricians, hugely important in this, 7 days a week ideally, because that's again turning a lot of the hospital sort of occupancy to defined by the frail elderly in the population. So actually, how do we stop them coming in, or if they are coming in, picked up by front door geriatricians, and actually how they're turned around as fast as they can? It's about what matters to the patient. Most patients would not want to be in hospital and actually get home. It's also speaking to families. Families sometimes think, well, they'll be safer in hospital. Actually having that straight conversation about deconditioning the risk of admission, and doing that always to avoid escalation. When you're in escalation, you have really frank conversations in the front door. Obviously, 7-day working across the system, be that primary care, social care. We often tip over on weekends because there's less cover. Sickness happens 7 days a week. We have to do that, and discharge services as well. As a lot of hospital discharges disappear over weekends. Actually, well, discharge service has to be there, and clinical cover has to be there as well. So every speciality should have representation in the weekend. In most hospitals, for looking at discharge and sick people, again to keep flow going, to stop the system going into crisis. Next slide, please. And what can be done about individual patients? Well, end of life planning and support. Most patients with a life-limiting illness, be that heart failure, be that cancer, be that COPD, should have a plan in place. People in care homes should have senior cares and discussions about it. The mortality going to a care home is 100% ultimately. So actually, we should have that in place. And actually, if we have that in place, we need to get sick people who need to come to hospital need to come. Those that are not sick should not come, and especially if you're dying, a dignified death in somewhere you're comfortable with a plan in place is far better. we know this is going to happen in care homes and for other conditions, and having those conversations up front. And if they haven't been had, they can be had in the community on the day. They don't have to be sent in because someone's not had a conversation. We can have those conversations there and then. Making sure medication is available for end of life in the community and care homes. Make sure there's senior decision support on weekends and out of hours for these decisions. You can ring up an ED, have a conversation. Will you do anything with this patient? No. Then don't bring them. From in terms of discharge planning, well, we can pre-purchase care home beds for discharges. We know difficult times of year like Christmas, we're actually trying to purchase capacity planning, discharge to assess, keep that going. And don't keep people in hospital or omit them in case something happens. It might go wrong, or anything might go wrong. It's about the risk of that and talking to the patient about that. And embrace the risk. Ask the patient what they want. Ask what they're worried about. Ask what they're scared about, and be honest about the risk of staying in and going home. And actually how we could manage at home, particularly with support of relatives. Other thing we can use to keep people at home, not admitting, but also or discharging people in these virtual wards. And these have been proven to work. They're not set up in many places, but setting things like that up will avoid crisis situations and escalation. But actually, the other thing it will do is it will, if you are in crisis, it may allow us to facilitate people to feel comfortable to discharge people or not admit them if they feel that safety net is in place. And we'll stop there. Thank you.